Hi, my name is Peter Llewellyn of NetworkPharma TV. This is one of my unscripted conversations, as I like to call them, where I get to chat with folks who I think will have something interesting to share with us. So let's see what we learn today. And today I'm joined by Lawrence Sherman. Thank you very much, Lawrence, for joining me. Lawrence Sherman of Meducate Global. And I've known you, Lawrence, I guess, for 18 years. When I set up the European CME Forum with Eugene Pozniak. I know you're passionate about delivering effective medical education for today's learners, which is what I'd like to talk to you about today. I know you travel the world pursuing that aim. So we'll talk about that and what that looks like in practice. But can we start with you just telling us a little bit about yourself, briefly introducing yourself, where you are now and how you got there, sort of thing, yeah?
Sure. Well, it's nice to see you. And yeah, it's almost our 18th anniversary, Peter. So people can celebrate. So I have been involved in health professions education, and I use that broader term because it's not just medical education anymore, and it's for all the broad team and members of the team for well over 30 years at this point. And I started out working in the sort of the CPD, CME space and broadened that out. I was a provider of clinical continuing education for over 25 years. And then more recently, over the last 6 or 7 years, I've really focused on making better educators, assessing the way CPD is done around the world, helping to improve CPD literacy, but also helping to train the educators around the world to be more effective educators. And we could talk a little bit more about that later, but I mean, that's the passion that I have. I run Meducate Global, as you said. I'm based in Florida in the US, but most of the work that I do is everywhere but here. And I really enjoy what I'm doing. And Peter, I'm at the point in my career where while I still need to make a living, I want to make a difference. And that's what I'm trying to do.
Excellent, excellent. Well, you certainly travel the world. I do sort of follow you on the various social medias, and you've got quite a travel schedule there. So specifically, we're having this conversation because we're in the run-up to the 18th European CME Forum. And as we both said, I mean, it's been an interesting 18 years, but it's a bit of a milestone to get to 18. So that's coming up for the purpose of people watching this. It'll be November 2025. CMEforum.org is the place to go if you want to find out more information, or if it's post-November, go back and have a look at what happened. And I know that you've been involved pretty much in every one, haven't you? I think. But this one that's coming up, I think the session title is something like engineering effective engagement in medical education, and that's your session, as it were. So let's just take that as a starting point. Tell us just a little bit about what you're trying to do in that session, and then let's broaden it out, because this idea of effective medical education, what does that mean? How do you measure it? Which is always a bit of a thing I get a little bit sort of excitable about. But anyway, you tell us a little bit, set the scene for the meeting. Just use that as the basis, and then we'll go from there.
Sure. And yes, I have indeed been a part of and in attendance at every one of the prior 17, and I will be at the 18th CME Forum. I think there's only 3 of us that have that can say that. I think it's Eugene, it's Robin Stevenson, and it's me. And I think I'm sort of the outlier because I live over here, not over there.
Yeah.
So the session is interesting. I'll be doing it collaboratively in person with Katie Lucero, who is the Chief Impact Officer of Medscape, a big, wonderful organization based here in the US, and developing it collaboratively with Don Moore, who, to your point, is the godfather of CME outcomes and measurement. And the premise of the session is really, how can we ensure that we are engaging the learners of today with the education that we're designing, developing, delivering, and evaluating, and engaging them from the beginning through the end? Because that's the challenge. How do we get them? How do we attract them? How do we keep them? How do we teach them? And how do we make sure that we did what we said we were going to do?
Absolutely. And okay, so I'm just going to let you talk a little bit. So what does that look like in practice? What are the challenges that you're facing?
Well, I think there's multiple parts to that. And we just talked about this on a planning call a couple of days ago. But, there are different models in health professions education and in CME and CPD specifically. Some providers, those who deliver the education, own their audience. So if you're a hospital, a health system, you have your audience. It's a lot easier to get the content across to them. But there's a big section of CME and CPD providers around the world who have to create the audience, either each time or for each iteration of an educational activity. And that's an incredible challenge because our healthcare professionals are challenged with time and resources and lots of other things to be able to participate in the education. So the first step in engagement is getting them. How do we make the education so that it's something that they want and need? The second part, and this is the one that I really focus on a lot in my day job, is how do we make sure that we are engaging the learners during the education? It used to be some expert would stand up on a stage and just say, here's everything that I know about toenail fungus. Big deal. The people in the audience, the majority of them, don't need everything that that person knows. But the educator was educating about what they knew rather than facilitating the learning, helping the participants learn what they need to know. And engagement is one of those things, and I say this a lot, Peter, is you're never going to engage 100% of the people with 100% of the content 100% of the time. And you shouldn't think that you will, because we as adults, every one of us have our own particular interests, needs, wants, and what we find relevant. So if during that education, we engage our learners the right way at the right time for what they need, then we've done what we were supposed to do. And then the third part of that continuum is how do we engage them at the end? How do we make sure that we engage them to either give them a call to action or ask them if they learned something, the outcomes component? How do we make sure that we are constantly, consistently using a continuum of assessment and engagement throughout the course of an educational activity, initiative, throughout the lifespan of whatever that content is?
So let's just say those three steps that we're getting them there in the first place. I mean, just talk a little bit about how important is the accreditation tool in whatever system there is. And obviously you have a global view and systems vary around the globe. So let's not get too bogged down in this, but let's just ask a simple question. How important is it that education is accredited in any way? Or do the healthcare professionals, do they just want to learn anyway? Is there some magic answer? But just, I'm setting you up slightly with this one, I know, but just talk around that a little bit.
Yeah, it's a great question too, because it's something we think about all the time. And I do have a global perspective. It's part of the research that I've done over the past few years. But I would sum it up by saying accreditation matters where accreditation matters. And by that, I mean, there are places in this world where accreditation is incredibly important. It guarantees independence. It guarantees some level of quality. It guarantees for the learner that they're in an environment that is safe, comfortable, and they are getting education that is unbiased, untainted, and independent. That's incredibly important. The asterisk to that, Peter, is that there are places around the world where either accreditation doesn't exist, accreditation systems aren't as strong as they are in other places, but there's work going on now. The International Academy of CPD Accreditation is working to help standardize what accreditation systems should look like around the world. And they have these criteria of recognition that the WFME, the World Federation of Medical Education, has recently adopted, so that there is a global standard of what a CPD system, an accreditation system, should look like, should smell like, should taste like. And it's been the work of really top leaders to put that in place. And there's, 30, 40 countries that participate in that academy, but there's so many other countries where the accreditation doesn't exist. Here's the caveat to that. The caveat is whether accreditation is in place, on an activity, lifelong learning and CPD will always happen because our healthcare professionals are committed to lifelong learning. And as adults, when a question arises in clinical practice, they will seek the answer. That is the purest definition of CPD. There's a question, there's an answer, and they fixed whatever the problem is.
Okay. And I mean, I don't want to get too bogged down in some of the interesting areas, which we could spend a lot of time talking about. But I remember, in terms of European CME Forum, part of the reason we set that up 18 years ago was because it was very at an early stage in Europe, there were lots and lots of differing sort of bodies and activities going. And the interesting contrast was with the States, the US, where you were, and the much more rigorous system, as it were. I mean, when you're talking about global standards and so on, just bring me up to date, because it's a few years since I've been involved. I mean, how is that working out in the likes of Europe, where there are so many competing sort of interests and so on?
Well, so there are two major accrediting bodies that are pan-European. Every country has their own system, and we have to remember, and I always have to remind people that Europe is a continent, not a country.
Yeah.
It's hard, and I know you know that, but there are people that I know that don't always think about that. So it's hard to compare the US to Europe because it's a country versus a continent. But there are two systems in place that they have substantive equivalence between the US system and the European systems, the EAC CME and EBAC, not the cardiology EBAC, but the broad EBAC.
Right.
European Board for Accreditation and CPD. And what's important is they are members of that international academy that I talked about before, so that they are all following. Not every system has to look exactly the same, but if they follow the same guidelines and principles of independence, which is really key, and design, delivery, and evaluation, things like that, you're going to find that the learners will experience good education, regardless of whether the systems look exactly alike. ACCME doesn't do everything the way EACCME does, and EACCME doesn't do everything the way EBAC does, and there are so many other systems. But with substantive equivalence in the work of the International Academy, we can be sure that anybody that adheres to these standards will be working in an environment and learning in an environment that's safe, protected, and comfortable.
Okay. And then to touch on potentially an interesting area in itself, the funding side of things. I mean, and specifically in terms of the sort of industry we work in, how pharma companies get involved in that as funders. Just again, give us some sense of how that works these days.
Well, it's not very different from when you were involved, in greater time commitment. But at the end of the day, pharmaceutical companies still have offices of medical education, whether it be in their global office or in their affiliate offices and things like that. And they are still funding independent education. The balance between independent education funding and funding of company-led education, which is developed by the pharmaceutical companies, it varies year on year, and sort of the pendulum swings back and forth. But there's still a fair amount of funding that's provided for education, with the understanding that the majority of that is in the US and Western Europe, and the rest of the world gets a lot smaller percentage of that big pot of gold that's being funded. And there's a greater percentage of the CME and CPD around the world that is not funded by industry than is. Here's the sort of the asterisk to that, though. In the research that we did and we published last year, there are some places around the world where the only continuing education available to practitioners in some countries is what is delivered by the pharmaceutical companies themselves. So the systems vary. If we want to keep it to the world that we live in the US and Western Europe, it's very tightly regulated. It is very independent, but there are places that are not that sophisticated with systems, but the education is still important and valuable. And if you look at the broad term of CPD, you take the accredited stuff, the not accredited stuff, the promotional stuff, all of that fits into that big box of what these healthcare professionals need to learn.
Okay. And there's lots of areas we could discuss in more detail there. And I'd encourage people, if they're listening to this, to follow up. I mean, apart from everything else on NetworkPharma TV, we've got loads of videos, and the European CME Forum as a repository of information and so on. I'm particularly interested in getting to the guts of what I was hoping this conversation would be about, in terms of what is effective medical education. And that, as I see it, I mean, that's your sort of passion, as it were. You know, what makes effective medical, whatever the regulatory context was. Let's just get down to what is going to make effective medical education in the room, as it were, for the people involved.
And it's a continuum, Peter. right? Because health professions education starts out undergraduate, where you're in medical school, nursing school, dental school, pharmacy school, whatever. And you're learning as a student, and that's pedagogy. And we hear that word a lot, and it's sometimes misused. It's used correctly when we're talking about teaching the students. It really means teaching children, but when you're teaching students who are there and their minds are open and ready, and they know that you're going to be giving them a lot of information, that's pedagogy. When we transition into practice, then you have people who are transitioning from being pedagogical learners to andragogical learners. They are learning as adults. They're problem driven. They're looking for answers to questions. They have the foundational knowledge and they build on it. There's a third part of this that most people don't talk about, and I will only talk about briefly, but it's called heutagogy. And heutagogy is where you're out there and you are self-directed, self-determining what your education needs are and where you find it, and you go for it. So it's a continuum. The consistent theme throughout is that the education has to be based on what the learners need. So when you're a student, you need everything. When you're a trainee, you need contextually everything. When you're a practitioner, you have very specific needs, and you don't need all of the information that may be in some CME or CPD activity, but there's going to be a part of it that you need, and that's where you need to focus. So the effective education, and you know where I'm going with this, it's dependent on the person teaching it, not on the person learning it. And we have to do a really good job. And there's a whole profession of health professions education to make sure that those who are teaching in those different sections, undergraduate, postgraduate, CPD, have the competencies to teach these people the way they need to learn. And in CPD, which is, I think, the place you want to talk about, we have to remember that it's not about an expert getting up on a stage and telling everybody in the room everything they know about a topic. That is not effective continuing education. That's lecturing. I believe in the UK, you still have people called readers. The reason they were called readers is they opened a big old book and they read what was in the book to the students. That does not work with adults like you and me, right? We need to be engaged a different way. And I will say that our research indicates that the majority of people who teach in CME and CPD have not been trained effectively as educators. It doesn't mean they're not good, but they haven't been taught how to teach. They haven't been taught how to engage. They haven't been taught what adult learning means. So they simply teach the way they were taught, or sometimes there are people who teach in undergraduate. They just teach the same way in postgraduate and CPD, and it's not as effective as using the right principles and practices, the art, not the science, of effective education. And that's why I stopped calling myself an educator a long time ago, and I started calling myself a learning facilitator. An educator teaches you everything they know. A learning facilitator helps you learn what you need to know.
But everybody learns in different ways. Everyone's, by definition, what you're saying, they're learning in different ways, and their interests and what they need to learn at any particular point is very different. So coming down back to the basic question of effective education of a group of people, how do you deal with all those differences within the group? Or do you logically end up with a situation where somehow you have to teach in each independent person independently? Do you see what I mean?
Yeah, so everybody has their own personal learning network, how they learn. Everybody learns differently. That's one of the competencies that we have to teach the learning facilitator, the person teaching, is how do you know who's in the room and what are their needs? When I give a lecture, and I give a lot of lectures and I do a lot of teaching, I always start out with an in-room needs assessment. Who's there? What do they know? Why did they pick that session? What do they need to know? Blah, blah, blah. So that I am never delivering the same content the same way to an audience. It's always customized. It's always based on who's in the room and what are their needs. That's a skill that the educators need to have. But to your point, a lot of the educators are not taught how to do that. They don't. So they go up and they teach and they get frustrated when people aren't immediately saying, oh yeah, that makes sense, because everybody learns differently at different rates. They have different needs. They have different interests. There's a slide that I like to use when I teach about presentation and communication skills to educators. It's a Venn diagram. One says what you want to say, and the other circle says what they want to hear. And the overlap I call relevance. And if you can aim for relevance, you're going to make a difference. And to get a little geeky here, there's cognitive load theory. Cognitive load theory means that the stuff that's coming in is broken into three parts: intrinsic, extrinsic, and germane. Extrinsic is noise. You don't want to fill that room with noise. Intrinsic is what they need to hear, but it's overly complicated, so it needs to be simplified and broken down. Germane is the contextually relevant part that they need, each individual needs. And so if we teach our educators, learning facilitators, to aim for that germane section of cognitive load, teach what needs to be known, we'll do a better job at health professions education.
To be slightly flippant about it, I mean, it did amuse me in the early days of European CME Forum when I was involved, and we'd have, you know, Professor X standing up on stage saying, you know, the worst way to teach is just to give a lecture. But what they did for 30 minutes was just read off their slides and give us a lecture sort of thing. I think it was much better at European CME Forum when we made it much more about panels and questioning and Q&A and all the rest of it. And I'm sure that's what goes on now. But it requires a confidence, doesn't it? And I guess that's one of the things. It's not just teaching these educators the skills, it's the confidence, because, you know, it's just so much easier to stand up with a prepared lecture than it is to do what you're suggesting you do, which is stand at the front of a room and go, okay, what do we need to do today? And then adapt to that. That's a big confidence leap apart from anything else, isn't it?
It's a confidence and a competence leap. And it doesn't mean people are incompetent. I mean competence in the ability to apply what we know. And it's a huge deal. And it's not just educators. Peter, I spend a lot of time working with people who just have to give presentations, presentation skills training, or who have to have conversations, one-on-one, one-on-two, one-on-five, communication skills. It's about applying how adults learn, how the adult brain works, and getting that transfer, the magic to happen of what you say to get people to learn something or to be interested in something, and then maybe to make a change over time. So yeah, it's definitely a confidence thing, but it's easy, and I say that sort of tongue in cheek, to get people to that confident and competent point because there's a strategy to be able to do that. However, the people have to be willing to learn. And it goes back to that old saying, culture eats strategy for breakfast, lunch, and dinner. If the culture or the environment that people are in are not supportive of that type of communication, presentation, or teaching, then you could have the greatest strategy to employ it and it won't work.
And so when you're teaching, when you're educating your educators, is a lot of the time spent on this sort of aspect, you know, building that confidence and the ability and the competence to deliver like that? Or how much of it is just simple presentation skills, storytelling, you know, whatever, you see what I mean? So again, just give me a sense of that. But I know this is, you know, this is the new business you've set up. It's effectively educating educators, isn't it? So, you know, does a course spend a lot of time on that sort of how to put a PowerPoint presentation together and how to present it or how to tell a story? Or is it much more about the sorts of things that you're actually talking about?
You're going to hate my answer. It depends.
It depends. Yeah.
Because it depends who's in the room.
Okay.
What
Yeah.
I
Okay.
find is when I go to a conference and I do a pre-conference workshop on this, let's say it's an educational conference, the people that often self-select to come in and participate and pay extra money for a presentation skills workshop don't need it as much as the people who should be in there and aren't, because the people who are good already want to be better. The people who don't realize that they need to improve are not yet self-aware that there's an opportunity to make it better. So every room is different. In fact, just last week I was in Africa and I did a session. And during that session, somebody gave me a question that I never had before. He was an undergraduate medical school professor and a pastor. And he said, can you help me in both? And it was great because we had a great conversation, a great dialogue. And what was to me so nice about it was no one had ever asked me that question before. So it made me think, it challenged me. And it speaks to something that most adults need to embrace, is being curious, remain curious. How can I be better? What am I doing? What can I do differently? All of that stuff. We need that.
And again, I'm feeding you a line here. Pick it up and run with it for a moment. I know one of your things is using comedy. Can I use it like that, or humor in your presentations? Just talk a little bit about that, because you've got an interesting background from that point of view.
Sure. So I've done stand-up comedy. In fact, I've done it at Carnegie Hall, or those who are watching from Scotland will call it Carnegie Hall. But it's one of those things where people say humor is so important in a good presenter. Can you make me funny? And the answer is you can't make somebody funny. If somebody's incredibly dull and boring, you probably cannot make them funny. But what you can do is you can teach them to use different methods that we use in comedy to be better at engaging, better at thinking, and maybe even get funny. One of the things I use is improv. And in improv, you have to be thinking fast on your feet. You have to be like ahead of the curve. And there are exercises that I use in some of the courses that I lead to help presenters think better on their feet, because people want to be better question answers, panelists, and things like that. Improv helps you think that way. So yeah, there are some things that are out of comedy that really help a presenter. And I will say that I always say that doing stand-up comedy in Brooklyn and New York was the single best thing to prepare me to be an effective communicator and presenter.
Okay. Okay. And to throw, again, it's a slightly obvious question. I don't know whether it opens up a can of worms, as it were. But is it more effective? Is that the right way of putting this? To educate the educators face to face versus online? Well, how do you feel about that? Because obviously we're at a time when a lot has gone online. There's a lot of logic to it, but it's not the same as being face to face. So let's just stick with that. Educating educators. Do you find it more effective online or face to face, or is it just different?
It's different. It's also cultural. There are places where digital education works incredibly well, connectivity is high, all of that stuff works, and people are able to participate. There are other places where the only way you can guarantee engagement and participation is to do it face to face. So it really is cultural. I will say this, though. During the very early days of the pandemic, which is so long ago now, I worked collaboratively with AME, the International Association of Health Professions Education, to help upskill medical and other health profession school faculty to transition from teaching face-to-face to teaching virtually. And we had thousands of participants from over 100 countries connect real-time and archive to learn this, and they were able to do it. So the answer is, when the need exists and the environment supports it, you can do it regardless of setting.
Okay. And we are running out of time. So I don't want to miss the third part of this conversation, which is about the measurement. And you've mentioned Don Moore is part of your session in Manchester coming up, and so on and so forth. So we haven't got a lot of time, but just talk a little bit about the importance of trying to figure out whether the education's had any effect at all. And I know we've gone a long way beyond numbers of bums on seats, as it were. It's more about what happens in practice. But again, it's a big topic. Just give us a sense of where you're at with that.
I'll summarize it by saying we need to make sure that we have taught the right people the right information so that they can take that information, process it, and at the right time apply it and make changes if necessary. But what we've learned through the years is that people learn at different rates and people require multiple educational interventions. We can't expect that everybody's going to participate in one meeting, one webinar, and everybody is going to make a change the next day. So there's a lot of factors involved, but we can only measure changes in what we aimed to change. And what I mean is, if we're only teaching something so that we're changing knowledge, we can't then say, well, people will change behavior, because we're only teaching them some new information. So we have to make sure that we are measuring the right level of impact based on what we were trying to teach. And a 15-minute webinar is not going to teach you a new surgical procedure. And if anybody says you can participate in a 15-minute webinar and you are now certified to go do a new surgical procedure, do not go to that surgeon.
And that can get very complicated, can't it? I mean, especially with behavioral change and so on. And how would you be following up an educational activity to see whether behaviorally someone has changed?
If we aimed to change behavior during the education, we need to tell them that we are going to follow up with you to determine if you made the changes. That's still only self-reporting. So it's me saying, Peter, we're going to follow up with you in a month. Tell me what changes you made. There are more highly sophisticated methods of using charts and electronic health records and things like that to see actual changes in behavior. But that's expensive, it's time consuming, and it requires a high level of commitment. So in reality, we're only as good as the information we can get and the data that can be provided. And oftentimes it's self-reported data. And more often than not, learners, when they leave an educational setting, they're not tasked with a call to action to say, we have to come back and learn what you did differently. So it's also incumbent upon those educators and providers to have a system in place so that they can at least test some of the sample to see what changes might have been made.
Okay. Just as a way of wrapping up, but I think, you touched on it to begin with, but it's an important point. So let's just finish on this. It's, we think in terms of CME, whatever, as being medics. You made a very important point to begin with about it being healthcare professionals and the team approach. One of the things, again, I remember about the European CME Forum is we sort of went through that journey very early on and started recognizing and talking about the team approach. So I just thought, maybe by way of finishing, I mean, I just think that's an important message to get out there, that when we're looking at developing educational programs, probably, is it fair to say, we should all be thinking more than we do at the moment about it being a team approach? Is that a fair thing to say, or are people already doing that already?
Yes, but there are certain topics that should be taught to the individual professions individually. The interprofessional, which is what the term that we're talking about, which is the team-based education with representatives of multiple professions, medicine, nursing, pharmacy, whatever. The education needs to be developed so that the learners have an opportunity to learn from, with, and about each other. There need to be team-based gaps and team-based outcomes. Otherwise, if you develop education, you say, oh, we'll invite everybody. The nurses can come, the pharmacists can come. We call that interprofessional by invitation, but not by design. And so the education has to be relevant contextually and content-wise to the team and to the people who are participating. Otherwise, it's not truly team-based education. We're just saying anybody can listen, but it's not designed for you. So you have to be intentional about how it's developed.
But in the context of this, where do you sit in terms of, bringing patients into the educational activity?
Patients are a member of the interprofessional team, as are their families and caregivers. Right. And in fact, they need to be a part of the discussion. And early on, I was using patients as faculty to teach at CME and CPD activities. Their needs, their environment are the central point. So not just the patient voice, but the patient focus needs to be included where appropriate, when appropriate, and cannot be ignored.
Yeah. So there's a whole discussion in there, and I'm just glad that we sort of got that in at the end, sort of thing, to make people think a little bit about it. So look, Lawrence, I could sit here talking to you for ages, and I know you've got lots of great experience, and the stories and so on you tell, absolutely fascinating. I wish you well in Manchester. If people are watching this after November, please go and find out what happened at cmeforum.org. But Lawrence, I know I can speak for you and say, if anyone's interested in anything like this, please follow up with LinkedIn. That's the easy way. Yeah. and you're happy to talk to whoever about all of this, and carry on your world travels, trying out cuisine all over the world. So I've seen the photos, mate. I know you enjoy that aspect of it, but I think this is really important, because otherwise, what's the point if we don't, delivering medical education? We need to know it's effective, we need to measure it, and so on and so forth. So a lot of what you talked about is really important. Sorry, go on.
And yeah, and just to wrap it up, it's not just for CME, it's for everything. It's for the company.
Exactly, yeah.
It's for the promotional education. It all boils down to making sure the person who's teaching is prepared so that they can incorporate the skills and competencies necessary to make the change happen. Otherwise, you're just up there as a talking head.
Exactly. Okay, right. Let's draw the line there. Thank you very much for joining us. As I say, people can follow up with LinkedIn. And if people are interested in what I'm doing, NetworkPharma TV, or contact me via LinkedIn, obviously. But thanks so much, Lawrence. Take care. Let's give a little wave and we'll stop the recording there. Take care. Bye.